Dr. Fendrick is going to discuss the work that he's done on getting the right drugs to the right patients and the impact it has, and then the progress that is being made. And with respect to the whole issue of having more voices, this is a very, very good time politically and from a regulatory standpoint for more voices to weigh in on not just value-based insurance design, but insurance design that recognizes that more and more medicines are targeted for specific people and specific conditions.
I still practice general internal medicine at the University of Michigan, where I run the Center for Value-Based Insurance Design. I had the great pleasure to be introduced to the U.S. Congress as the shallowest person in American medicine, which my fellow academics would find as an insult, but I have had a pretty broad-ranging career. I've worked in a lot of areas, including looking at the cost of the common cold, blockbuster drugs, health IT, health reform. I was actually the guy who coined the term the Katie Couric effect, which I should have trademarked, but I wasn't smart enough to do that. But my wife likes to say I published and I still perished, which is why I am here talking to you, because I think this is a great opportunity to hear from a lot of experts and stakeholders in the room around a small solution to the issues that were raised in the first panel. I think interesting and elevated in the fact that it is easy to explain, which I may achieve that, and also that it has broad multi-stakeholder and rare bipartisan political support, which is, I think, one of the reasons why value-based insurance design was mentioned even before I got to the microphone. So it's very interesting, and this is an unusual meeting in Washington where a lot of time was spent talking about the health of our population. Nick and I thank you for that, because most of the time when I run into Washington, 9 out of 10 comments are talking about the cost of care. And my opinion, at least, is all my time I spend on the Hill and talking to both the past and current administration is how to lower healthcare costs. I like to tell people I did not go to medical school to learn how to save people money, nor did any of my pharmacists, nurses, respiratory therapists, and the hundreds of thousands of clinicians in this country, and I think it's really important to restore health to these healthcare cost discussions. If I were to ask any of the stakeholders, thank you, what we should be spending our money on, I think or ask any of you, I think all of you would acknowledge that the most important things that we should be spending our money on are underutilized, and that we actually have to spend more. And I usually look to see where the exit is before I tell any stakeholder that we have to spend more on healthcare than we're spending now if we're going to achieve those goals of individual and population health. Because my career has not been based on cost of care, but it's the underutilization of things that I beg my patients to do, whether it be prevention, diagnostic tests, chronic care of diseases, or end-of-life care, as we look at the things that we should be doing for which the evidence is strong, whether it come from clinical trials or real-world evidence. There is substantial underutilization of those things. I mean, the biggest myth in Washington is that people believe that the improvement of high-quality healthcare actually will lower healthcare costs. They hardly ever do. That has been my holy grail, but it shouldn't lower healthcare costs. Living longer, better lives is something we should invest in. We have to change the healthcare conversation from how much we spend to how well we spend it. I've been quite outspoken that if I were designing the American healthcare system from the bottom up, I wouldn't be kind of apologetic for 16% of the spend going to pharmaceuticals. I think it would probably be about 25%, given the data we have on safety and efficacy. So where's the rub? The rub is, when I think about what's coming down the pike, the innovations that are before me, I like to call them Star Wars science. And the world in which I practice, I like to call Flintstones delivery. And I think that before the ACA, there was quite a gap between what I could do and what I actually was able to do. And I'm sad to say, from my own individual perspective, I think that gap has gotten wider, not closer, even with the expansive insurance to millions of people. And I'm even more fearful that the gap is going to get wider and wider. I think every stakeholder sitting around the table should get serious about the identification, the measurement and removal of care that does not make anyone healthier. You could call it low-value care, you could call it wasteful care. I think it's the only opportunity we have over a couple years to maybe get rid of $600, or some people think $900 billion in services that do not make anyone healthier, to allow us the time to figure out how we are going to allocate the remaining money on services that actually work. So volume to value, I love saying because it's alliterative, and we were talking about value-based care long before it became popular in this town. We have to focus on providers and value-based payment, which I think there'll be some discussion later. Myself and Michael Chernew, ex-vice chair of MedPAC now at Harvard Medical School, have been working on patient-facing or consumer-facing initiatives for now getting on 2 decades, which is now called value-based insurance design. But what keeps me up at night are deductibles now, and the fact that my patients with commercial insurance or public insurance outside of Medicare actually have a donut hole at day 1 on January 1st. That's sometimes up to $12,000 for a family has to come out of their pocket before any insurance kicks in. And as I travel around the country, it's about deductibles. It's about co-payments and cost sharing, and the fact that I find it humiliating that my patients have to have a bake sale to pay for a drug that was designed to treat them. It's, this would be first line or targeted therapy. This is not overuse. These were not drugs that people want to take. These are drugs that are the only option for many of these people. So our small solution to this problem of cost-related non-adherence is what we call smart cost sharing, or we call it clinically nuanced cost sharing. It's the type of cost sharing that instead of basing my patients' out-of-pocket spending on what things cost, we base the out-of-pocket spending on the amount of health that would be produced. The issue with drugs or any clinical service, this nuance idea, there's no such thing as a high-value service or a low-value service. It depends on who gets it and when in the course of their disease, oftentimes by whom, and now with this interest, particularly Medicare on site of care, where it's provided. We've evolved value-based insurance design into something we call precision benefit design or dynamic benefit design. And I could give a number of examples of this, but the purchasers, that being the employers and the health plans and the PBMs, I get them on board because I say, and I strongly believe this, that we should support low-cost services first line if they're clinically indicated. Unfortunately, many of my patients, let's just say diabetes, since this is something that people know well, they take the low-cost generic drugs, they take all of them, they take them religiously at the maximal doses that allow, and they still need more. I find those patients who do everything they were supposed to do as advised by their plan in the PBM, why should they be penalized by their biology? So no one wants to pay more than the lowest price. But when your only option, as is a patient who fails generic therapy, or in the world coming into Star Wars medicine, the patient who has now received a genetic marker to say you should not take the low-cost drug, in fact, that might harm you, you must go for this drug that was designed for you. I strongly believe that those patients should not be penalized, but in fact should have a benefit design that makes those drugs affordable for them in that clinical instance. So you don't get to have the drug that you saw on TV first line if there is a low-cost alternative. But if you are unlucky enough to either not do well, have an allergy, or have some test that tells you you should not take it, you should not be penalized. And we call this precision benefit design. And we're just starting now to get organizations behind this, because the neat thing about precision benefit design, it is a strong commitment to first-line therapy and many of the situations that the plans have in place. But it appreciates what, in my opinion, is not appreciated now, is that the life of people is a dynamic process and not static. And I don't know, outside of 2 out of about 25,000, and maybe the folks in the PBM world could tell us, that actually have a different co-payment, co-insurance, or deductible for the same medication. And that's what I think we could take advantage of our multi-billion-dollar investment in health information technology, to which, in my opinion, has not at all benefited my patients as much as they benefited other parties in terms of charge chapter and other things. So the idea that the things that are most profitable in healthcare are not the things that produce the most health is the disconnect. And what I mean by that, I had the great honor to speak with Speaker Newt Gingrich when he was primarily a healthcare guy. And I said, this is the line I typically use when I talk to the Wall Street Journal or other types of places, that if we aligned profits with health, then I wouldn't have problems with profits because the monies would be going to the right things. And so what do I mean by that? So if I were to ask many of you, what are the most valuable things that we do in healthcare? Some of you, if not many of you, would say vaccines. And it turns out that our work in Michigan, now it's probably 5 or 6 years old, showed that over half of community-based pediatricians lose money vaccinating kids. And then when I asked the speaker, well, what do you think those pediatric practices have to do to make up for the losses they incurred for doing what many people thought was the most valuable thing they could do? Of course, he said right away, do a bunch of stuff that really doesn't help the kids very much. But people ask me all the time, well, low-value care is challenging. But the folks who showed up in the large firms that put VBID in place, who saw their visits to see nurse practitioners and they saw their insulin's cost sharing be cut in half, and they were actually not discouraged, but actually made easy for them to go to see the eye doctor. No one complained about that. And I think that if we put in the right balance, which is what I argue for anyone who works with me, well, the idea of removing low-value care to a payer is so attractive, almost red meat, because the savings are immediate and substantial. I think that what we've shown in the management of certain chronic diseases, that we could actually get to cost neutrality by having people be healthier, by having greater amounts of visits, and most importantly, filling their evidence-based indicated drugs. And I'll just again put it as a second thing, is aligned with the current recommendations that people stay within their tiers. And the worrisome for me with the VBID demo in Medicare is there's this term that I'm just getting used to in this town called PAYGO, is that to get the VBID demo to expand, we have to show that the programs that we have for the 10 chronic conditions have to be cost neutral at year 5. And while there are some conditions like congestive heart failure for the non-clinicians room, lots of avoidable hospitalizations, that's why people are jumping in that direction. But having advocated for other conditions like mental health issues like depression, we got rheumatoid arthritis added as well with dementia last time around, because I really wanted to see these demonstrations fall into those conditions where hospitalizations were not the cost drivers. But other issues would.
I think the positive conversation that this will drive, and it's going to be a hard one, but it's moving in the right direction, is what does value look like? How do you define value? Over what period of time?
My 2 words that I tend not to say in Washington are capitation and rationing. And I was asked about trying to get trapped in a recent hearing around the rationing issue, to which I say, I ration harmful care, right? It's really hard to argue against rationing harmful care. What is challenging is identifying what is harmful. But there are some things where we're starting, like Pap smears under the age of 21, and now Pap smears every year, now that everyone recommends it every 3. These are easier to identify. DEXA scanning. So our list of low-value services that we would start with, Peter, are not the ones that the CBO will want to see. These are not going to be gigantic chunks out of Medicare spending. What we are hoping to do, like we've done on high-value care, is to get people to understand, which we recently had some NPC-funded work to do, that people think it's too hard. And I think to get rid of 30% of waste, as Dr. Berwick thinks, I think that's hard. To get rid of 3%, to get a dialogue going that more is not better in this country, I think that is doable, and that's the way I kind of approach this thing.
Obviously on value-based care, my comments around taking that 10% of the prescription drug spend and really making sure that's synergistic with the 90%. I think that value-based care is a big part of that. I do think that, one of the things that was mentioned as far as the plan and the PBM driving the decision-making, I think that would be a concern from our vantage point, that really that should be driven by the provider, the physician, pharmacist, the healthcare team, really driving some of those decisions in conjunction with value-based principles. So it shouldn't just be a blank check, so to speak, but it should be something where there's value-based principles with actual healthcare providers helping to make those decisions. But again, I think, when we talk about PBMs and we talk about the current way that prescription drugs are paid for, it's a means to an end. That's a means to an end. The end is a better healthcare system, And the payment for prescription drugs is changing how it's currently paid for is one means to that. And I think incorporating more value-based principles is one way to get to this change in our overall healthcare system. And having, as the doctor said, controlling the growth, because it's not that we want to spend less, but it's the rate of growth that has been unsustainable and continues to lead to a higher and higher percentage of our GDP that's being occupied by healthcare.
So, very much involved in essential health benefits of the IOM. You know that is 10 relative to about the 25,000. I'm not sure if we clinch the 25,000 things that I could do. So we've had lots of discussion, particularly since January 20th, about where ultimately things like clinical nuance and value-based insurance design fits into the essential health benefits discussion. And the answer is, if you go down any of those things, there are some things I really want to see covered for specific population for each of those 10. I also think there are some substantial amounts of at least generosity of coverage that could be reduced for certain services for other types of populations within those 10. So it's really the idea of whether you take moving money within or among those 10 things. If the organizations, particularly those that represent patients, do not get serious about low-value care reduction, I'm going to use an academic term here, we're screwed. No, because when I think about 400, the idea of being able to take cells from one of my patients' bodies and have them put into those bodies and have that drug only available to them, I'm not sure what the price of that should be, but damn it, I want to be able to use that drug, right? And if I'm going to be able to use that drug, and I'm not sure how many payers are in the room, they'll say, that's fine. You want more eye exams, Mark? Great, as long as it's not going to cost me anymore. Because some consultant came in and told me that this high quality care is going to lower my total spend, which I wish I could come to the National Press Club or anywhere to say I believe that's true. And I think that is the biggest issue that we have to overcome. So most of you are in health plans that you pay the same co-insurance for all specialty drugs.
Right.
You pay the same percentage for a drug that will cure cancer 90% of the time as the same for a drug that will never cure a case. And I ask CFOs of Fortune 50 companies every week, like, you went to Wharton, you went to Harvard, you went to Stanford, and this is how you're spending your money on specialty drugs? To which the typical response is, tell me this isn't true. How did it happen and how do we fix it? I said, I don't know, value-based insurance design, right? I mean, the point is that the current one-size-fits-all, even within the tier, makes no sense. 90% of the attention and the urgency in the world of prescription drug is talking about drug classes across, within the tier. Generics first, brand. This idea, that cheap drugs are cheap to patients, we have to fix that. And I think that particularly the National Community Pharmacists Association, I think can get behind that and try to help us. If we're going and closing, I think Nick said it best. I mean, my view in this town is that people do care more about money than they do about individual and population health. We have to get this conversation back to the patient.
Here, here.